in low-income families again. So you've seen that. The one on the right is another way of looking at how well the services work. So this is school readiness for those children who are getting free school meals in year one in school. So how well are children who are getting free school meals being educated and getting ready for school? And you can see the northeast stands out as the only big, large green area in the country. Some amber bits as well, but large parts of countries you wouldn't expect in the south of England are red here. The children in the south of England who are on free school meals are not being looked after as well as children in the northeast on average. And again, London's got some green bits, interestingly, rather than red bits. And I think that's probably around areas which have a higher proportion of children on free school meals can actually better understand their needs and can cater for them better, and give them better support, rather than those areas where there's far fewer children on free school meals and they aren't as focused on those children in terms of their learning, is my hypothesis on that. I'd be interested if anybody else either agrees or disagrees as an alternative view. Then let's move into adults. I'm afraid the picture doesn't get any better. North-south, pretty much north-south divide, or no, actually the Midlands, which is awful, across the whole of the country. This is the percentage of adults classified as overweight or obese. And this is a pretty scary number. For the whole country, it's about 2/3 of adults in the country now overweight or obese, which is very worrying for the long-term health trends. The northeast, big red spot again up here largely. And again, there's a strong correlation with affluence here, even though it's more spread out. Obesity is a problem across all levels of society, but it's an even greater problem in the more challenged parts. And then smoking prevalence for adults. Now again, smoking prevalence here, there's the big problems across these red bits in the Midlands, but the northeast only a few red bits. And that's because we've had a very integrated, systematic approach to this for a number of years through a regional approach through what we call the Fresh organisation. And that's made quite an impact. So if we hadn't have done the impact we've had, that would have been all red in the northeast. So we've actually had some impact with our intervention. And then I want to just show you, again, the challenge and the success here. So the one on the left here, the challenge, this I showed you that one earlier. This is the mortality from causes considered preventable. If you look on the right, this is under 75 mortality rate for cardiovascular disease. And you would expect all of this in the northeast again to be red. And a lot of it's amber. There are 2-3 red authorities, but most of it's amber. And again, where the reason for that is we've had a very systematic approach in the northeast of England and very north of England to cardiovascular disease prevention for a long time. And the impact, we haven't managed to turn it green yet, but we have managed to reduce some of the impacts to more of an amber status, which is very important. And if we look at some of our programs and how well we run our programs, this is bowel screening coverage. So the red area is the lowest bowel screening coverage. The amber, the medium, and the green are all doing very well. So most of the country, excuse me, does quite well on bowel screening. The northeast doesn't really stand out. A couple of reds and 2 or 3 ambers. But you wouldn't really look at that and say we've got a massive problem compared to other parts of the country, particularly low in London. London has the most concentrated problem in implementing the bowel screening program by quite some distance down here. So we don't really stand out as having a massive problem. We could do better, of course, like it ought to be green, but it doesn't stand out like some of the other measures. So that tells you that the organisation of the services and the access to the services is quite good. This is for cervical cancer screening. And again, mostly green in the northeast, apart from Middlesbrough and Newcastle just popping up red a little bit. But most of the rest of the country is green, apart from, again, London, very deep red. And these clusters in here, some big red patches. So again, this is telling us the organisation of the services and the access to the services in the northeast is as good as anywhere else in the country, really, again, apart from those two places. And then the other one is breast screening. And again, look at London again. Very, very poor uptake of breast screening services in London. The northeast, one little red in Middlesbrough, that's all. But the rest, the big chunks of red there in West Yorkshire and parts of Lancashire, and down the south coast. That's that's Sussex down there. That's Brighton and Eastbourne and places like that, and Hastings. Very low, again, poor coverage of breast screening down there. So all of that is those three slides actually demonstrate that on average, on big screening programs, we are organising our services quite well, which is somewhat reassuring. However, pre-pandemic, if you look at the pattern for life expectancy for women, then you get that unfortunate pattern. Vast areas, the whole north of England, red, apart from this big chunk which is Yorkshire and East Riding and the amber bit, the city of York. Big, vast red swathe across the middle of the country from Humberside, across all of South and West Yorkshire and all of Lancashire and Manchester and Liverpool, where life expectancy is much lower for women than it is in the amber and the green areas, which are predominantly further south, apart from the Yorkshire part. Say the North Yorkshire, the East Riding of Yorkshire, and the city of York are actually quite affluent. The rest of Yorkshire is not quite so fortunate. So that's and I could show the same picture for men. The reason I show women in these talks is that we often focus on male life expectancy. And actually, I think we could do a lot more on female life expectancy, and we need to think about that, especially if you have things like the breast screening programs, cervical screening programs, and think about access to those programs. They undoubtedly are good programs that save women's lives. The other area which we pay too little attention to is mental ill health. So it's quite well known that people with mental ill health also have quite significant physical health problems. People with severe mental illness have a much shorter life expectancy than those without severe mental illness. And also severe mental illness is very much exacerbated by poverty, poor socioeconomic conditions. And a lot of mental illness then gets into the toxic mix of drugs and alcohol as well. And it causes great amount of distress and inequality and challenges for those people. But you can also see with some physical illnesses, just on this chart here, which Public Health England produced, that people with severe mental illness have a rate of obesity 1.8 times higher than those who don't. They have a higher rate of asthma. They have a higher rate of diabetes, a higher rate of chronic obstructive pulmonary disease, COPD. They have a higher rate of coronary heart disease. They have a higher rate of stroke. They have a higher rate of heart failure. And what often happens is that these physical illnesses sometimes get overlooked while people are focused on the management and dealing with the mental ill health. Somebody with severe mental illness needs their diabetes treated every bit as effectively as somebody who doesn't have a severe mental illness. The COPD figures, where it's more than double the background rate, is because smoking prevalence is very high amongst people with severe mental illness. Well, they have every right to have the same support to help them stop smoking if they wish than people who don't have severe mental illness. And sometimes we say, well, the severely mentally ill, they've got whatever condition it is, and smoking helps them cope. Smoking kills them. That's all it does. It kills them earlier. So I don't think a strategy of helping them cope by giving them something that kills them earlier is a particularly good plan. And you can see this, almost certainly the reason the COPD is much higher is because of the much higher smoking rate. Although, of course, it will also contribute to exacerbation of asthma, a complication of diabetes, and is a major causative factor of coronary heart disease and stroke and heart failure. So it isn't doing them any good whatsoever. On smoking, just show you a bit of graph here to show you that we intervene sometimes to help when things intervene when things are going badly. So this goes back to 1998, this graph, and the red line is smoking prevalence for England. The dark blue line is smoking prevalence for the northeast of England. And they were both very high, around up to 2000, 2001, but the red line kept coming down and the blue line didn't. The blue line was pretty much horizontal. So by the time 2005 came, smoking prevalence in the northeast was about 28%, and in the rest of England it was about 23%. So a 5% gap had opened up. And we realised at the time that this had happened and we had to do something about it. So the NHS at the time, I was a director of public health in Middlesbrough at the time, and there was we were all in NHS primary care trusts then. And we all worked together with our NHS other colleagues, and we set up an office called Fresh, which was designed to tackle smoking at a more strategic level rather than just smoking cessation services across the whole northeast. So we did a lot of campaigning work on tobacco control. We did lots of publicity work. We found advocates. So again, for Middlesbrough, a little something you may not realise, but Middlesbrough Football Club, when it was in the Premier League in 2005, was the first Premier League team in the country to go entirely smoke-free, where you couldn't smoke anywhere in the premises, within the confines of the ground. Middlesbrough Town Hall, Middlesbrough Council banned smoking at Middlesbrough Town Hall 2 years before the smoking ban came into place in July 2007. So through that campaigning work, we've got action taken early in the northeast, and you can see the blue line then came down much faster from 2005 to about 2008-9. And it only took us 3 to 4 years to close the gap. The gap was marginally opened up again, but now it's in parallel largely. So we need to do more, but we have much narrower gap now than we used to have between smoking rates in the northeast and smoking rates in England. And the smoking rates during that period came down faster in the northeast than the other part of the country. And that has other benefits. So if you look at this graph, so I want to get across that whilst the inequalities we face are stark, then there are things we can do about them, and there are things we have done about them in the past. So I just want to spend a bit of time explaining the story behind this particular chart. It's one of my favourites. So in 2000, if you look back, we were looking at mortality from acute myocardial infarction, heart attacks. And in 2000, there was a new report came out. It was called the National Framework for Coronary Heart Disease, National Service Framework for Coronary Heart Disease. So there's a new plan in the country. And the reason that came about, a bit of a story for you, is the then government at the time, Secretary of State for Health, was based in the northeast, and he was concerned that some of his constituents were waiting up to 18 months for heart operations, and some sadly died while they were waiting, and he got very frustrated and upset over this, and oversaw the introduction of a new framework to radically reduce waiting times for patients for things like stents were really invented then, things like bypass operations and heart operations. And he also did an awful lot more on prevention of heart disease. So there was a work program set up across the northeast, which I chaired the Teesside bit for quite a while, and we looked at a number of aspects of heart disease. We looked long-term at prevention. So GPs really changed how they looked at prevention and did a lot more work on routine blood pressure checks, cholesterol checks, prescribing statins. Statins were already coming on the market and from 1996, 1997 onwards, so they were a newer drug then. So we did a lot about prescribing of statins, checking blood pressure, a huge investment in smoking cessation services and tobacco control, and we also invested in hospital, secondary and tertiary services for heart disease. Middlesbrough and Newcastle were the first hospitals in the country in 2007-8 to do primary angioplasties for heart attacks, and we started to make a difference in this. In 2000, if I'd have said to the GPs or the cardiologists in Middlesbrough, we'll have the heart attack mortality rate below national average within 15 years, they'd have laughed at me. And we actually did it in about 11 or 12 years. We actually got the heart attack mortality rate down to the England average by 2011-12. The data on here shows it's for men it's below that average. The latest data, not on this chart, shows that women are continuing to narrow the gap and have narrowed the gap now. And if I show you the next graph, just to show you how the overall, there's also been massive improvement in the country on this. So the blue lines are 1995, and the light brown are 20 years later in 2015. So the change over 20 years in heart attack mortality rate for each region of England. So the left-hand side, you can see the northeast are the highest mortality rate in the country for heart attacks for men. And London had the lowest on the left-hand side in 1995. And then the southeast and east of England. So if you actually look where we are now, there's two things happened. The browns are the current. So the whole country, mortality from heart attacks in the country has dropped dramatically, which is a good thing for everybody. But also the inequality is reduced. So the northeast now has the third lowest mortality for heart attacks in men in the country, having previously had the highest. So there's two huge stories in this: the overall drop and the change in inequalities. And this has been brought about through much, much better primary prevention, heart attack statins, a massive reduction in smoking prevalence. Smoking that counts as something like 50% of the cause of heart attacks. And a big investment in hospital services as well. Still a way to go in other cardiovascular diseases, and nobody's complacent. But this does show that if you actually have a plan and implement the plan at scale, then you can actually make a difference. So this is a success story, both nationally and regionally. However, look at some latest data. This is emergency admissions. I have to explain this one carefully. The black horizontal line is my reference line. That's quintile 5. That's the most affluent 20% of society. And then what we're measuring is the rate ratio compared to the most affluent. So if it's below it, then they've got better access to the most affluent. If it's above it, they've got poorer access. And I mean access there, because if you look at the right-hand end, the 74-year-olds, this bit here, sorry, the 70-74-year-olds here, or the 75 to 79-year-olds here, the blue line is the most deprived. So they have non-elective emergency hospital admissions for different types of cardiovascular disease, which will largely be strokes, heart failure, heart attacks, here, nearly double the rate of the most affluent. Now, on the one hand, you could say, well, actually, they're getting better access because there's more of them getting all that access. However, the true story, this is the elective admissions. So if they were getting sufficient treatment, they would be preventing these heart attacks and they wouldn't be needing them and these strokes. So there's a differential here where the lower end of society in socioeconomic terms are far, far greater users of the hospital services for cardiovascular disease for acute emergencies than the most affluent. And that's because of poverty, diet, smoking, lifestyle, other obesity, cold housing, having worked as well in harder physical jobs over their lives. Whole raft of reasons as to why these people here end up with a far greater burden of emergency cardiovascular disease care, almost really from the 40s. Starts in the 40s. In the very young age, 30, 34s, there's not a lot of difference. But then, if anything down here, heart disease, which requires non-elective admissions or stroke, is incredibly rare at these young ages. It's when it starts to build up here in the 40s through the 50s There's consistently a pattern here. And also, if we're not careful, things can get worse, not better. So this is Middlesbrough. The under 75 mortality rate for preventable cardiovascular disease, narrowing the gap quite nicely to about 2010-ish there. And then Middlesbrough starting to widen the gap again. So the gap in Middlesbrough most recent data, which is 15 to 17 over here, is actually as big as it was nearly 20 years ago, 2001 to 3. So for 10 years, we worked to narrow the gap, got the gap narrowed, and it's widened again. But the gap now is as big as it was 20 years ago, if not bigger, which is really, in fact, definitely bigger, which is really not a good place to be, and something we absolutely need to refocus our efforts on. And then if we look again at the pattern slightly more around the country, this is looking at the whole northeast. You might not be able to see them, but different northeast councils listed here. Most of them red. This is again cardiovascular disease, which is preventable. Again, you see another example. The northeast here overall narrowing the gap, but then that gap staying there rather than completely closing. And then here, a scatter diagram of under 75 mortality against deprivation index, and you can see the strong correlation, the very strong correlation with mortality with deprivation index for cardiovascular disease. Again, be no surprise for anybody. And if we actually choose a different disease, choose cancer. If you look here again, the cancer rates, again, cancer considered preventable from under 75, much higher across the whole northeast of England, down to Northumberland amber, but that's again related to affluence. The top right, very strong correlation again between mortality and deprivation. What's worrying on this one particularly, if you look at these graphs here, a little bit of narrowing, but we really haven't made enough impact over 20 years in this. In fact, the most recent data shows this widening again as well. So we haven't really had the impact we ought to have had on this over the years, and this is not good. And the next slide before we have a short break and I have a rest. Again, this is more recent data from Public Health England. This is life expectancy widening, particularly in the first graph for men. The gap between the lowest and the richest in different areas growing quite substantially. The slope as measured by the slope index of inequality, and for women it's down here. It's widened quite a lot. So in a nutshell, we had 10 years where we made some progress. We narrowed some life inequality, narrowed some inequalities, particularly life expectancy. Unfortunately, the last few years, last 10 years or so, the last 5 years, the gap's starting to widen again, and we need to do something to address that. So what I'm going to do now is hopefully stop sharing my screen for a couple of minutes. You should be able to see me again. Is that right?
Yes.
Yeah. See me again? Excellent.
Yes.
So that's the end of the first part. I just want to give a bit of context, the type of inequalities that we're dealing with and working with as we headed into the pandemic, because that's a pattern across the north. A lot of maps, a lot of information to digest. Within all that information, I'd say there's a fairly simple, stark message. The north-south divide is very much with us. When we think of the north, remember it's also parts of South Yorkshire and Lancashire as well. It's not just the northeast of England. We can do some inequalities when we have a plan and we invest in it properly, and we go at it systematically. We definitely can do that, and we've done that in the past. And we know at the moment inequalities are, this is again before I show you some pandemic work, inequalities are getting worse, not better. So I've sort of caught up my time a little bit. I'm very happy to take any quick comments or questions now before we have a 5-minute comfort break. Any colleagues got any comments or any questions? There's a few actually in the chat, so I'm going to start going through the chat. Can I max out? Yeah. Okay, I will try and improve the screen for the second bit. I'm struggling a little bit at the IT this end. Three major. I'll try and go through the question here, then I'll pick up questions with hands up as well. So, major cause of child abuse in the past and now in Middlesbrough. That's a really excellent question. Well, one is, I think, poor parenting, if I'm being honest. I think two is poverty. And I would say, if I was going to, so poverty would be first, actually. Poverty does unfortunately lead to some poor parenting. And those two things, the consequence of those two things lead to very poor diet and lack of exercise. So that's a very short answer to a very complex issue. And why still Middlesbrough lacking public health awareness? I think it's something. I think there's something about, again, I'm afraid, poverty. Middlesbrough is one of the poorest towns in England when you look at the statistics. A Teesside University colleague told me 20 years ago, if parents have very little money, they'll fill their children's stomachs with the cheapest food they can find, because that's all they can afford, and they don't want the children to be hungry. But some of that cheap food is high fat, highly processed food, and that's and all the consequences you get of that then is sadly some child obesity. Just an example. In the case of breast screening services, depending upon which criteria, is it called a successful screening program? Ultimately, the whole point of a breast screening program is to reduce mortality from breast cancer. That's its prime purpose. And you can always, there's a whole quality assurance program where you're improving constantly the quality of the breast screening service. And that's right from the access to it, to get as many women as possible through the program, to the quality of the screening and the screening experience, through to the quality of any intervention that's needed because of any breast abnormalities that are found. So in terms of access, the point I was making is that despite the challenge in our part of the country, our access issues, at least for the uptake of breast screening, is no worse than anywhere else. It's actually better in a lot of parts of the country. The ultimate outcome, of course, is mortality, is reducing mortality from breast cancer. And breast cancer is one of those cancers, actually, which is more associated with, well, it's less associated with poverty and more actually with affluence. Being a public health expert, am I happy with current waiting time at Page Hospital? And what's your thoughts on video consultation with GPs by patient? Two questions there. Right. Am I happy? Well, nobody's happy with the current waiting times. I mean, nobody could possibly be happy with waiting times in hospitals at all. We've probably got personal experience with them as well as professional views. The NHS is working very, very hard to try and address them. The pressure it's been under the last 18 months, 2 years has been quite incredible. But I'm certainly happy about them. My thoughts on video consultation of GPs by patients. I think this will vary on patient experience. I think it's too simplistic to simply say we've all got to go back to seeing the GP face to face. I think some patients can actually have a better experience by having a video consultation, and some patients will feel it's a poor experience. I think there's a lot of work and research done, to be honest. I think at the moment we're all talking anecdote, and I think what's lacking is some really good quality research into this, to be perfectly honest, because it's really exploded through the pandemic. And I've heard lots of stories and not seen enough high quality research into the question. Are there not specific reasons in the North East respond to this huge disparity in health? Not really. I mean, it's I mean, if you look at Middlesbrough, I mean, half the town of Middlesbrough lives in poverty, frankly. Hartlepool, Sunderland are not much different. There's large parts of the North East and also the post-industrial North East in County Durham and Easington and places where there's enormous problems. Northumberland and Darlington do quite well, but then they are much richer than the rest of the North East. So I do think it's more of a wider North East problem than just specific pockets. And then Charles, paradox of the North East, North of England Foundation. Ought to be more economically vibrant. Well, yes, absolutely should. You get here into a bigger problem because in England, the southeast of England and London, does act as a bit of a vortex and sucks things in, and that's been a problem for many years. The government's trying to address that through its levelling up strategy, through things like whether you agree with it or not, but HS2 rail link is meant to open up the country more as well to make it more economically balanced. There's no question that the long-term structural solution to some of the inequalities is to have a more structured, a balanced economy. But we aren't the only country in the world with this. If any of you ever go to Italy, the north of Italy is incredibly prosperous, and the south of Italy is really quite poor. There are other countries as well around the world, I'm sure you'll all be aware of. So I think I've dealt with the questions in the chat. There are some hands up, or a hand up. Is that Haida or Shafqat? Sorry, I don't know which way around the name is. Would you like to ask your question?
Yes, if you could hear me.
I can hear you, yes. You're very quiet.
Can you hear me now?
I can now, you're a bit louder. Yeah, you have to speak up.
Very good morning. I want to raise issues. First of all, how about a lot of child obesity? I want to how far the school health programs are taking part to reduce the child obesity. And second, I have noticed in the young generations of Middlesbrough, there is a tendency of going towards drug addiction. What are the causes for that? And how far health inequality is causing it to disperse or raise in such a big way?
Okay, I think the reception is very poor there. I think the first question was about child obesity, and the second was about drug addiction problems in Middlesbrough. Is that correct?
Exactly. I want to know how the school health program in obesity is acting to reduce it.
Do you want to come here? Use this microphone. Turn that microphone off.
Yeah, that will be much better.
Oh, that's a lot better. Try again then. That's a lot better. Right.
Hello. Can you hear us, Peter?
That's much better now. Yes.
Okay. If you could turn. Sorry, we're live streaming in one of the big lecture theatres.
Oh right. Wow. Okay.
Access the talk outside of that. So, and I just realised that the question would come from within the room, so I'm just going to let the student speak.
Hello, now I think my voice. Yeah.
No, I'm getting lots of echoes now, I'm afraid. Shall I try? I'll comment on. You might have to turn the feedback on. So you turn the go on mute, and I'll try and do some.
Try that.
Hello. Still quiet. So whatever. The thing is, regarding childhood obesity, how the school health programs are actually taking part to reduce the childhood obesity, especially in the northeast of England. And secondly, regarding drug addiction, the young generation of northeast England, we are seeing a good number of people are addicted towards drugs.
Right.
And what are the steps as a public health expert you want to take to directly intervene these issues?
Right. Okay. I think first of all, if everybody in the room could go on mute, that would help.
If you're here, what you do, just put your.
Sorry. People go on mute. Yeah. Everybody goes on mute in the call. We'll stop the feedback. Then I'll speak. Okay, that's much better. Okay, right. So I'll try and pick up both of those. So the question about school health approaches to obesity. I think we have to be very careful over this, because if you actually look at the data, then the data tells us that the obesity problem starts before children go to school. So around 10% of children are overweight or obese as they start school at 4 or 5 years old. So that's a real problem in itself. So there's something happening from when they are born to when they start school, which has got nothing to do with school. A lot of them start obese. A lot of them are also on a trajectory where they are overweight through their primary school years into their and before they even go to secondary school. So by the time we get to 11-year-old in Middlesbrough, 1/3 of children are overweight or obese. by the time they start secondary school in Middlesbrough. And I think the schools have a part to play in the solution through nutrition education. But actually, again, ultimately, the children's diet to be dictated by their parents. And that'll be dictated by their parents' affluence or lack of affluence, the parents' knowledge and skills, and the parents' education levels. And so the work has to be in a whole system work, not just on, although it's very important, not just through schools. And it's also increasingly, I think we saw kids doing more exercise. Well, they do need more exercise, but actually, if we don't get the diet bit right and improve the diet bit, then they need an awful lot of exercise to put that bit right. So I think it's a very, very complex area. Schools are mixed in their ability to be able to deal with this. Some do have some very good programs, some less so. But I wouldn't be critical of schools or the school health program, because I'd say I think it starts with birth, with breastfeeding. We have very low breastfeeding rates in Middlesbrough, with early development, and all the things I've just talked about, and also the environment that we live in. We do live in what's called an obesogenic environment now, I would suggest, rather than a healthier environment, surrounded by the ease of access of processed food and fast food. The second question was around drug problems. Middlesbrough sadly has had serious drug problems for decades, and a lot of it goes back to, Middlesbrough is a big port. I think drugs have been imported into Middlesbrough for decades, and then get distributed around the country. And sadly, again, and this isn't unique to Middlesbrough. Middlesbrough is, drug addiction is very, very strongly linked to poverty again, and sadly, Middlesbrough has more than its fair share of poverty. I think there's something about aspiration in young people. I think we've got a lot of poverty of aspiration and poverty of hope. Some people just can't see any hope in life, and they turn to addiction, and they might have very few prospects of a good job, very few prospects of a happy family life and partnerships and things like that in life. And I go back to Middlesbrough. I am from Middlesbrough. I was educated in Middlesbrough. I went to comprehensive in Middlesbrough in the 1970s. Much of my family still lives in Middlesbrough. I do feel I know the place pretty much inside out. And I think Middlesbrough, as a town and as part of Teesside, has, I can say this, lacked a bit of an ambition. I think Teesside University is an incredible institution. And the way Teesside University developed the last 20, 25 years, when I left in 1999, is incredible. I just wish the rest of Middlesbrough and Teesside had shown the same ambition as Teesside University for its development, because I do think that as a corporate civic society, we haven't quite had the same ambition. I think that would in turn help with poverty. That builds hope and aspiration, and that then reduces the problem of drug addiction. But it's a massively complex problem. I've got two more hands up, then we're going to have a short break, because I need a glass of water, and then we'll kick off the second part on COVID in a second or two. So if the hands could come off mic only and then ask the questions, then we'll move on. I think one's Turner Mithali. Yes. Somebody chip in, ask the question, and then I'll see if I can deal with it.
Hi, so Turner's going to come down to the front.
Okay.
I think we're working properly now without sounding like we're
Right.
all underwater.
Okay. Brilliant.
Thank you.
Hello, Peter. Good morning. Greetings.
Hi, good morning, Turner.
Okay,
Thank
I
you.
already heard about the school health services and parental education. So, as a public health expert, what do you think that what policy should we take as mandatory in case of parental education in Middlesbrough?
Sorry, what should be mandatory? Sorry, the reception
What
wasn't
kind
great.
of policy should we take in case of parental education in Middlesbrough for reducing childhood obesity? Parental education, educational policy.
Sorry, okay. We used to do a lot more parental education. a lot more many years ago, and we seem to have dropped doing that. I mean, it is sadly true. There's been big reductions in public health spending in recent years. We've not been quite in the same position to do some of that investment that we've wanted to do. I think parental education, though, there's formal, there's informal, and one of the huge changes over in recent years is, of course, social media, the internet, and the way people access information. And I think we could be a lot clever, a lot smarter in public health as to how we get across positive messages around parenting. And of course, a lot of parents learn to be parents from the people around them, from their associates, from their brothers and sisters, siblings, from their parents. And we've had, I would suggest, a history of poor parenting in Middlesbrough going back quite a few generations in some parts of Middlesbrough. So I do think there's a bit of a cycle to break there, and I think it's the parenting. Actually, again, I think it cuts across all of society. I think it's something which we need to be getting to help people who are in their 30s and 40s who are becoming grandparents to learn how to be parents, their children to be better parents. I'm not sure mandating it in any sort of way would necessarily be very effective. And what you probably find is you'll get the people who you're not really worried about coming to those services, and the people who need them the most will be avoiding them. I am conscious of time, but I'm very happy to take questions as well. I love taking questions. So, any more questions, then I'll do all I can to answer them. Osmar Duman has a question, and Masvare has a question. Want to come off mute or go down to the front and try and ask?
Okay, they're not in the big room.
They're not in the big room. Okay.
No, so they must be at home. So,
okay. Well, we'll move on if we can then, because I'm conscious of time.
Yeah.
Can I do a 5-minute comfort break? 'Cause I'm conscious of 2 hours of this is hard for everybody, and then I'll start. Time's it now? 1 minute past. I'll start literally at 6 minutes past 10. Is that okay with the room? So a very quick comfort break, and I can reload the slides. Yeah.
Yeah, that's great for us over here, Peter. We're going to keep the recording going if that's okay, and then there's not two separate recordings.
That's
so
fine.
If anyone's at home, just be aware that if you do put your microphone on, you are still being recorded in the break time.
Brilliant.
Okay. Thank you, Peter.
Time 5 minutes. Thank you. Okay.
That's great.
Thanks.
Thank you.
Bye.
হ্যালো, আসসালামু আলাইকুম। জি, কেমন আছেন? আচ্ছা।
Okay, I'll just do a sound check again, please. It's 6 minutes past, and I'll start the second part. Can people hear me?
Yeah.
Yeah, brilliant. Okay, I'll start then, colleagues. Am I okay in the big lecture theatre to start?
Yes, we can.
Brilliant. Brilliant. Okay, if people could then go on mute then, everybody. And that'd be helpful. Thank you. And again, I'll take questions again. So this is a change of tone. So I'm now going to reflect on the pandemic. I'll do a little bit of background stuff on infectious diseases, but 3 or 4 slides to start with. So this is part a little bit of reflection on the pandemic, and it's part looking at inequalities and what we've learned about inequalities through the pandemic and the impact of the pandemic on different sections of society. Just by way of background, in terms of my role, as Regional Director of Public Health, I've had really overarching public health responsibility for managing the pandemic for the North East and Yorkshire since it came along. That does involve an awful lot of intense work through the whole time with politicians in particular. So I have been doing weekly calls with the Chief Medical Officer, Chris Whitty, and also with the Secretary of State for about 18 months now, certainly about, nearly 18 months. So on Tuesday, we have a routine, we have what's called the Silver Meeting, and I have one later today, where people like me around the country have a meeting with Chris Whitty and some of the epidemiologists nationally, and we go over the epidemiology of the pandemic. And then on a Wednesday, we have what's called a Gold Meeting, which is a meeting which is used to be chaired by Matt Hancock, now chaired by Sajid Javid, or one of the junior ministers. And we go over, again with them, some of the key points and get asked any questions by the politicians. So I've been sort of privy to the thinking through most of this. So what I'm going to share today is information which is all in the public domain, and some of it's what we learnt last year, and some of it's what we've learned since, and it'll also show you some of the patterns of infectious disease. But I want to remind people that pandemics are not new. Sorry, next slide. Pandemics are not new. So here's a list of them. Take your pick. Look one up yourself if you're interested. When you actually look back through history and do a very bit of a study, you can find we've had all sorts of pandemics throughout history. Obviously, the further back we go, the harder they are to get good information on historically, and you're relying on all sorts of ancient history texts. But some of them have some quite good information on them. So I'm just going to pick on a couple of them just by way of setting a little bit more context. But all of those pandemics have had impacts upon society in general. Well, nearly all of them, not quite all of them. A lot of them had had major impacts on society. The plague of Justinian in AD 541 to 542 was really brought down a large part of the Roman Empire. The Black Death, which hit Europe from 1346 to 1353, was probably the most fatal pandemic recorded, depending upon different estimates. And again, getting historical sources that are accurate on this is very, very difficult. But the most common estimate that you hear is that about a third of the population of Europe died. And actually, if you track the spread of this plague back, it goes back across Asia, across the old Silk Road, and you can see city after city as it moved west was obliterated by this plague. Went into cities like Venice, which are big trading cities in those days, and spread from Venice through trading routes around Europe. Like I say, large parts of the West, the developed world, really were absolutely obliterated by this plague, and it had profound impact upon society afterwards, because the labour force, the workforce, had dramatically changed because so many people had died. And then we had a couple of 100 years, 300 years later, there was a great plague of London, where London lost about 15% of its population. And that was a very large specific impact. Didn't spread to the same degree around the rest of the country, but an enormous impact upon London. But if you go to the Victorian era, where public health started to emerge a little bit through the work of John Snow and the work around clean water, even in the Victorian era, we had some major massive infectious disease problems. So in Sunderland in the northeast, a case arrived there, and we ended up with 52,000 deaths over 2 years. Measles and whooping cough used to be real killers before we had vaccinations and better treatments, and it was commonplace for flu to kill thousands year by year. And on average, it's estimated between 60 and 70,000 deaths per decade of Queen Victoria's reign were due to these different types of infectious disease. And it did lead to a greater awakening in terms of understanding how infections spread, understanding that cholera was a waterborne disease and not an airborne disease, understanding the importance of clean water and sewage, good sewerage systems. And there were big reductions by the end of the Victorian era, but nevertheless, it was a massive problem. So moving on to where we are now, we had this virus called SARS-19 COVID come along, or COVID as we're all calling it, and I'm going to show you the track of the spread of the disease now over the till September last year. And I'll just talk to this slowly. There's a lot of colours on this line. You can see at the bottom, there's 9 regions of the country. Each is a different colour. The northeast is the dark blue. London is the orange one. And it started September last year, September 2020, because this is case rate data for 100,000 population. During the summer last year, we had very low cases. But when we had the first wave of the pandemic, which was from February till about May, June 2020, we can't really compare the case rate data because we weren't testing as many people. We had nothing like the same access to testing. So over this time period, we've had about the same access to testing. So it's a fairer picture, because the number of cases you get is clearly going to depend upon how often you test people. So just talking through this, the patterns in this, because this will be relevant to how I talk about some of this the next half hour or so. So on the left, in September last year, you can see that the blue lines, the northeast, the northwest, and then the sort of light green and pale green line, the Yorkshire, Humber and East Midlands, all took off quite steeply in September. Whereas the orange, the red, and the yellow line sort of stayed a lot flatter. They increased, but didn't increase as fast as the others. And that was largely due to universities and university towns, largely in the northeast and northwest, getting hit very early by students going back, and very rapid spread of the virus. Newcastle peaked to a massive rate in about the last week of September last year. And then we had, follow the date line across the bottom. It takes you through to November, and in November it comes right down again. There's a dip. It's like a roller coaster, goes up, goes across the top, and comes down with a dip. That's when we had lockdown. That was the second lockdown on November the 4th. The Prime Minister brought a lockdown into place for 4 weeks, and you can see from November, if you look at the scale at the bottom, from early November to early December, the rates come down pretty much across the country quite fast in the northeast, the northwest, Yorkshire, but still slow down everywhere. Then you've got at the beginning of December, the lockdown ended. Everybody's promised Christmas, and you can see the rate in London in particular shoots up, goes very, very high to what was then the highest rates that we'd had in the country, about 1,100 per 100,000. And not far behind it, the east of England and the southeast, and the northeast and the north stayed about where we'd got to in September, October. We didn't shoot up in the same way, and it flies up to a peak, and it peaks around the 5th, 6th of January. And again, there was another lockdown brought in just I think on the 4th or 5th of January, and what's brought it all down was the lockdown. Because lockdowns, if you actually want to focus just on case rate and forget and put to one side the collateral damage of a lockdown and the other impacts it has, because there are undoubtedly adverse impacts of a lockdown, we all know that. But if your measure is reducing infection only, then lockdowns are the most effective way of reducing infection, with vaccination, which I'll come to in a second. So it comes plummeting down at the beginning of this year, and the vaccine program then started as well. So we kept it down right through. It came down rapidly towards the end of March, April. Yorkshire stayed high a little bit, and there was some interest and attention to that nationally, but we've got them all down to about the end of May. Now, what happened in May then, you can see the line start to increase. The northeast started to go steeply. The northwest went first. That middle blue line, the paler blue line, is the northwest. And that started to kick off, if you look at the scale, around the end of April, early May. And at that time, that was when the new Indian variant, as we called it, the Delta variant, as it became known, took off. And the Delta variant originated in Asia, and through international travel came to the northwest of England first before it came to the rest of the country, and then came into the northeast of England and Yorkshire, because there's a lot more connections between the subcontinent of India and Pakistan and Bangladesh and those areas and other parts of the country, and the rates went up. And the northeast went the next one to go really high, the dark blue line. And then that plummeted rapidly, because we also had on top of that, we had the Euros and all the football. So everybody was mixing like madly during the Euros, and that pushed the rate up as well. And Wimbledon also had people on. And by now, we hadn't vaccinated, of course, younger people in this group. We'd vaccinated the older people. So people my age were double vaccinated and older people vaccinated. But we hadn't really got to vaccinating younger adults here. So the cases went up high, but the hospital pressures didn't, because the cases were largely in younger people. And the vaccine was holding very effectively for people over age 50, who were largely by then very high numbers double vaccinated, and lots of clinically vulnerable people were double vaccinated. So they had the benefit of the vaccination and of the lockdown earlier. Going into the summer we've just had, rates go right up. They then start to come down as the vaccination program kicked in to all ages. And then what you've got is a whole mishmash of wobbling along. what to describe. It's sort of hovering around 300 the rates. And we'll all know from the media we're getting roughly 40,000 cases every day now, virtually. The southwest has a couple of peaks. The dark red line. The first mini peak was a particular festival where there was thousands and thousands of young people went to Newquay in the southwest and spread COVID. And then the southwest other blip, the most recent data, is due largely to a lab failure where thousands of people who were tested positive were told they were negative, so kept doing the normal lives, and hence we had more infections there. So that's the overall pattern where we're at now. The next graph shows you the relation between, for northeastern Yorkshire, again, there's three measures on this graph. There's the orange line, which is the hospital bed occupancy, the blue line, which is the case rate, and the black lines are the weekly deaths. So I'm exploring here the relationship between case rates, hospital occupancy, and deaths. So again, if you go back the same time scale again, the case rate, the blue line, the case rates went high. You got this pattern I showed you for the northeast, peaked around the 4th of November. The blue line, you'll see the first peak of the first part of the blue line, peaked around the 4th of November, 4th, maybe 12th of November. The orange line was a hospital bed occupancy, which went up to 3,500 per our region, and the deaths went up to about 600 per day, 600 to 700 per day. And you can see the hospital bed occupancy peaks about 2 weeks after the case rate, and the deaths peak 2-3, maybe 3 weeks after the case rate, crudely. We then had the dip before Christmas, and then we had another smaller spike just in the 6th of January, the blue line. And again, the orange line is much higher than the blue line, the hospital beds, and the deaths again peaked about 4 weeks later at the end of January from that second peak. Bearing in mind, you're also then in the middle of winter, and you've got a lot of winter extra stresses on people's system, particularly vulnerable people. But if you then go through the summer, as the case rate dropped, the vaccination program kicks in, it gets very, very low through May and June, and then the blue line takes off very, very fast. The case rate goes up very, very fast to a peak around the 17th of July. But at the same time then, the hospital data is much lower this time. You can see the orange line is now much lower than the blue line. The deaths don't get anything like as high as they were previously. And this is entirely the impact of the vaccine. The vaccine is incredibly effective at doing the one thing the vaccine does brilliantly well is stop people dying of COVID. That's its number one job. And it does it very, very well. The mortality rates of people who are vaccinated are very, very low. And so hospital rates for people who are vaccinated are very, very low. So the vaccine, and I'll say more about this later on, is a massive success story. And you see the complete changing pattern. So now where we are, the current thinking with the government, we're currently in this Plan A situation, is that the government thinks the country can cope and is happy with the pressure on the NHS with these case rates. If we'd have had these case rates without the vaccine, I guarantee we'd be in lockdown now. 100% we would be in total lockdown. There would have been no other choice for any government if we hadn't have had the vaccine. The vaccine has prevented the country from going back into lockdown, and has been, as I say, enormously successful. The case rate is still going up. The hospitals are sneaking up a little bit, and now the problem is that the other hospital pressures more than normal winter pressures. So that's, if you like, where we are now. But I want to go back a little bit to what we learnt last year. So this now is after the first 5 months of the pandemic. So this is where we have to be careful we don't look back with rose-tinted spectacles or look back with the wisdom of hindsight. So this is what we knew in May 2020. So these are the age standardised mortality rates of deaths for the regions of England for 100,000 people by the end of May 2020, so 18 months ago. So London had by far the highest standard or age standardised mortality rate, and the southwest of England had by far the lowest. So there was a big regional gap, very big difference in where people were dying from COVID originally. And that's almost certainly, the London effect is almost certainly because London got hit very badly first with COVID. And again, I can't recall, but I may have some information on that a bit later. London got hit very, very badly first. And there was certainly, again, with hindsight, and hindsight's a wonderful thing, there is, I think, the evidence that if we'd had an earlier lockdown in March last year, we would have had lesser impact, I think is probably quite strong. However, put ourselves back in that position then, and did we know that at the time? Well, no, we didn't, because we didn't have a crystal ball. So we have to be very careful and make judgments about decisions people have made, judging at what they knew at the time, not what we subsequently learned. And then, and this is no surprise, and I remember saying to many people, why is anybody surprised at this? So we're using the least deprived, the left-hand end of this chart, as our baseline here. So all of these deaths, so the grey bars are all deaths, the blue bars are COVID deaths. All of these are referenced to the reference point of decile 10, the left-hand end, the least deprived. So you can see even the next least deprived has a slightly higher mortality rate for all causes of COVID over this period from March to 31st of May. And you go to the right-hand end of this, again, these are percentages, so these are rates. So the right-hand end, people in the most, and the second most, and almost in the third most deprived quintiles had double the rate of dying of COVID than people in the most affluent. And even people in even people in average in society, the middle decile, decile 5, say, even they had a 30 to 40% higher chance of dying of COVID than people who were the most wealthy, the richest decile in society. So we learnt that, we knew that then. We knew that because we had this data by June, July last year. So we knew early on, and again, I remember saying to many people, why is anybody surprised? I would have, everybody in public health would have predicted this. And then we look at ethnicity. And this is the data again. This is data that we had of May last year. So this is data we unpicked quite early on, and we knew this by May 2020. So these are the turquoise lines are males, the dark red lines are females, and these are age standardized mortality rates by ethnicity and sex. And again, you can see that you compare white British males in the turquoise on the left with black British males, then again the rate is much higher in the black ethnic group than the white ethnic group. The Asian group is much higher than the white group, but much lower than the black group. And mixed groups are somewhere in between again. And the same pattern also applies to females. Black women had far higher as a group mortality rates from COVID than white women. Asian women were somewhere in between, and the mixed ethnic groups, again, somewhere nearer the Asian group. The other group are a collection of other ethnicities, and people don't declare their ethnicity. So again, this was known to us last May, June. So the question is, I suppose, subsequently, what did we do about it? I just want to show you another way of looking at this, which is another way of looking at the deprivation data. This is looking at quintiles, again, rather than looking at deciles. And again, you see the same very strong linear relationship, really, quintile 1 down to quintile 5, in terms of risk, much higher risk in the as you go up through the quintiles. Again, highly predictable, unfortunately. So when we look at parts of places like Middlesbrough again, and Bradford, and Leicester, and Bolton, and Newcastle, places which have a mix of high ethnic minorities and a lot of poverty, that's where you've got a lot of higher endemic cases, and that's where you also got more hospital cases and more mortality. And that concoction, if you like, has led to more in what we call enduring transmission in some parts some part of the country. Now, the other thing to think about in all the back of this, though, is by far the biggest risk factor for COVID is simply age. So again, this is the early people who died from COVID. So again, this is the 13th of May last year. So these are the deaths in cohort 1 from COVID. So you can see this is before we had vaccination, anything like that, well before the vaccine was anywhere near ready. And you can see, first of all, the mortality rate per 100,000 is higher in males than females, and we found this all the way along. It's a ratio roughly of 6 to 4 of males to females, the risk of COVID in terms of mortality. Secondly, you can see how high the mortality rate per 100,000 is in the 80-year-old pluses. It really dominates the mortality. I think the median age of deaths is over 80 for COVID. So people who are old and frail are by far the most vulnerable to COVID. And even down to the 80 pluses compared to the 70, 79s, there's a massive leap from 70, 79 up to the 80s. And in fact, I've seen this data in other places broken down to over 90s. And again, there's a huge leap again. But that shouldn't surprise anybody, given old age, frailty and comorbidities. You can also see the mortality rates on people who are young, under 60, are very, very low. In fact, on this, they're not measurable under 20. On 20 to 39s, they're barely measurable as well. So one of the interesting things on the media coverage last year, there was, with all of us, some very tragic cases of younger people dying. They are, thank goodness, very rare. When you actually look at the data, and public health has to look at data in big patterns, and not as individuals. So the big patterns in this were certainly around the risk of old age. And it was this, which when the vaccination strategy came out, this is what drove the governments and the JCVI, the Joint Committee of Vaccination Immunisations, their thinking on who should be vaccinated first. They looked at this data and thought, this disease is killing people over 80 and over 70 in their thousands. We need to vaccinate them first. So out of this work last summer, we made some recommendations last summer. Oh, sorry, one more graph on this. Comorbidities. This is diabetes. Look at people with diabetes and how they've got on. And again, people with diabetes are at higher risk because diabetes is a disease which puts you at high risk of lots of things. But they're also at high risk of dying of COVID. And again, even here, there was a strong, if within a disease group, the disease of diabetes, there was a strong trend where the most deprived decile with diabetes were far more greater risk than people in the least deprived decile with diabetes. So whilst diabetes is a risk factor for everybody, the poorer you are, the greater the risk factor. A lot of that was linked into obesity, because obesity is quite a risk factor for the treatments at the time, because if someone's obese and they require ventilated oxygen, then actually it's harder to give them sufficient ventilated oxygen treatment because of the weight and the pressure on the lungs, because they're obese. So actually treating them is also harder. So these recommendations were made, mandating, and you might be thinking to yourself, as I was at the time, and lots of us were saying, why did it need this to actually make us do this? But we have tried to put these in place now. So mandate comprehensive and quality ethnicity data collection and recording in data systems, because actually we found we weren't doing that as systematically as we should be doing. Trying to do a lot more, and this second one's really important, doing a lot more understanding of communities to understand social, cultural, economic, religious issues which affect different communities and inequalities. And that's really important, because doing that properly ought to have informed how we went about marketing the vaccine programme, because vaccine uptake also varies by different ethnicities. So maybe we didn't quite do that as well as we should have. Improving access for people from all types of backgrounds to NHS services and to understand, so they would grow more understood. And going through, I won't go through every one here, but you can read them for yourself. Again, number 5, culturally competent and culturally aware COVID education, prevention campaigns, and doing them in partnership with local ethnic minority groups and faith communities. Again, something which across the North East, a lot of the DPHs have done very, very well. And then culturally targeted disease prevention programs as well. So lots of lessons to learn, and you may well be justified in saying, well, why did it take a pandemic to learn these lessons? But nevertheless, you've still got to keep learning, and we've got to try and make sure we do these and a lot more. So where were we towards the end of the year? So I did this slide for a talk in November, where I was looking at the deaths, the age distribution of deaths for the North East and Yorkshire. Again, trying to explain, again, the risk of age here. And this, again, was the type of information which was starting to be pulled together for JCVI when they planned the vaccination programme. Because remember, the vaccination programme started in December last year, so this was November last year. So again, you can see younger people. We lost 2 children, sadly, to COVID, or 0 to 14, in the first year of the pandemic. Both of those children, very tragically, were on life-limiting conditions, and were very, very sick children already. Still, nevertheless, a tragedy for their families. And again, relatively few younger people, 33 men and 36 women under 44, but nearly 4,000 people over 85. So a massive, again, so you can see from this, 93, 94% of the deaths were over 65, and 83% of the deaths were actually over 75. If you actually look at the totals on the left hand, overall, roughly. So, again, age coming through massively. The other information we look at in terms of inequalities, if you like, and also how the public has reacted to the pandemic, is workplace attendance. So this is a complicated slide, but there's one line I want you to look at really, which is the bottom line of this slide, is the grey line. This is from what we call Google mobility data. So Google come up with this data through tracking people's mobile phones and whether in workplace or whether at work and whether they're moving around. So it's background information that Google tracks. One of the things I've learned through this pandemic is how much information Google and other people actually have on us all through our mobile phones. That's maybe for another seminar, separate discussion. But the grey line at the bottom is London, and this is workplace attendance. So these are the regional averages for workplace attendance. So the North East is the purplish line, and it's more or less near the top for a lot of it. The reason for showing this goes right back to January this year. The reason for showing this is London has a far greater proportion of people who are able to work at home. Far more city office workers. There's far more industrial and manufacturing industry outside of London in all the other areas. Well, there's obviously some differences between the other areas. The southwest is generally the next lowest, and the north of England is generally the highest. But overall, the big gap between London and the rest. So even now, in recent months, you can see that across the country, we're about 20-25% below pre-pandemic workplace attendance across the country. London is 30-35% below pre-pandemic. So London's quite a way behind the rest in terms of its return to work, if you like, than the rest of the country, and that has impact upon the economy, upon jobs. It also has impact upon the spread of the infection, because actually the more people keep apart, the slower the infection spreads. Now let's talk about the vaccination, and particularly look at ethnicity. So again, look at the different groups on this. The group at the top, the brown group, is white British. The bottom group, the light blue line, are black British, and then the dark blue line are Asian British, excluding the Indian group, who are green group, separate. So you can see on there the different groups. Now this goes back to this is the northeast of England. This is our data. So I'm responsible overall for working with people to help people deliver this vaccination program, and you can see at the left hand side again. Immediately, almost in the first couple of weeks of starting the program, the uptake in the white groups was higher than the uptake in the non-white groups. And the Indian group stays close to the white group for quite a while and then starts to digress. But the black group really never starts off in a good place, and by the middle of the year was really dropping behind. And you can see the pattern now at the right hand end. That's the most recent data that we have, is that the uptake in the black groups is about 60-65% compared to around 90% over all ages in the white group. And it's not just the northeast of England, because I also cover Yorkshire, and in Yorkshire you get virtually the same graph. A little bit muddy the waters because of the not stated other ethnic groups, but you've still got the black and the Asian actually doing much worse in Yorkshire and the Humber than the white group. And again, in each case, it's the Indian group that does next best behind the white group, and the Indian subgroup has a much higher uptake than the other Asian groups and the black ethnic minority groups. So this is something which is of great concern, because we already know that these groups suffer greater inequalities because they experience more poverty, they have more crowded houses, and we have data from June last year which shows us that people in those areas are at higher risk of dying of COVID than the others. So therefore, when those groups at the highest risk of dying have the lowest uptake of the vaccine, that is of great concern to us. And there's an enormous amount of work going on to try and help improve that situation so that we can actually save more lives, frankly, by getting those people vaccinated as fast as possible. And I want to take you through a little story of how a variant emerged last year. You remember from the earlier graphs I was talking about the surge, which we had the November lockdown, and then through November it went right down, then it came right up again with what was called the Kent variant at the time. Well, I'll just show you how the Kent variant emerged. So the two graphs here of the country. So the graph on the left is the 12th of October to the 18th of October data. You can see the red bit in the northeast of England, the red bit in parts of the Midlands and South and West Yorkshire, and a very dark red bit in Lancashire and Bradford and Huddersfield. And in the bottom right corner is green, where there were very few cases, and that was Kent. So we were all looking, the whole country, we look at this data on a silver with Chris Whitty. We look at it then with it was Matt Hancock, wasn't Matt Hancock, it was Sajid Javid. Matt Hancock at the time, sorry, I get mixed up. Matt Hancock at the time, this is last year, 2020. And we go through the data, we have a report from each region, but most of the reports are focused on my part of the country and the Northwest and the Midlands. We then move to the right-hand graph on this page, which is the end of October, early November, and this is just before we went into the 4th of November lockdown. You can see the red spreading across more parts of the middle of the country, a bit of red down in the southwest. And Kent, by the way, just quietly turned orange in the bottom right-hand corner, and nobody really discussed it very much because we're all focusing still on all the big red bits. But then look at these two. So the one on the left is the 9th of November to the 15th of November, which is just after lockdown, so before the lockdown had kicked in. And you can see the whole top half of the country virtually was red. Kent, interestingly, had gone red in the bottom right part of the country, with some little areas around it as well, in parts of Essex and parts of London. And at that point, PHE was starting to look into what's going on in Kent, because we started to pick up this happening in Kent. And then particularly the right-hand one, the 30th of November to the 6th of December, that was a worrying one. Because what you've got there is a large part of the country have gone from red or dark red to amber or even yellowy green, even yellow. So the lockdown, because we spent all of November 2020 in lockdown. So the lockdown really worked for everywhere in the country, apart from Kent, where it got a lot worse. And the more we looked at Kent, the more we got worried. And also parts of Essex as well, it spread, and parts of southwest London. And that's when the Kent variant was discovered. because we had lots of genotyping of cases in those areas and found we had a different strain of the virus, different mutation. And that mutation then rapidly took over and swept across the entire country over the Christmas period and into the new year. It was only the vaccine program started on the 8th of December last year, and we were very lucky it did, because that actually did have some impact in slowing down the spread of that variant across the country. And two more things just to finish off on. First of all, mortality and the impact of the virus. I mentioned that the first slide was the impact of Great Plagues, the Black Death, or the Great Plague of London. At a time when the pandemic's over, we'll look back at this and we'll try and estimate how many people actually died from COVID, and there'll be bundles and bundles of research and PhDs and books written on that. Chris Whitty, the Chief Medical Officer, said very early on, the best measure to look at was simply excess deaths, because we know how many people die month by month, week by week, going back decades and decades, and we can always compare. That takes over years, that averages out seasonal effects. So if we look at the top graph here, this is going right to the beginning of the pandemic. So go back to January 2020, and you can see the first 10 weeks roughly of the year that we have little yellow lines just below the 5-year average. So we didn't have any extra, in fact we had slightly under normal mortality from the beginning of January 2020 to about the middle end of March. What's worth putting into context is if we'd gone back 3 months earlier or 2 months earlier to December and November 2019, we had an excess mortality because we had a very early nasty flu season. And what the public's not aware of really, or has forgotten, is that was a nasty flu season, and we did actually have sadly some child deaths. I think 11 or 12 children in the country died of flu in the November, December before the pandemic started. And certainly more children died of flu in those 2 months than died in the first half of the pandemic the next year. So it's, again, why flu vaccination is very important. The excess death rose very quickly then through March and April and peaked very rapidly around the Easter weekend, 9th, 10th of April 2020, and then came down much slower. We then had week 25, which is about late May, early June, right through to early September, a very quiet summer. So last year, it was just a normal year for excess deaths. It then picked up much slower. We had a much slower, longer period of excess deaths, starting around about early October, late September. The vaccine was put in place around week number 1. If you look at number 50 in the middle was when the vaccine was introduced, roughly. Vaccine was introduced, and the vaccine, because we were very fast at getting that early on, that suppressed the mortality in this year. So if you look at the number 1 in the middle of that graph, I don't know what the cursor's showing or not, middle of that chart, then we had about 8 weeks of excess mortality this year. We then had about 20 successive weeks where we had lower than seasonal average deaths. And then we've had about 10 to 12 weeks of, again, slightly higher, but nothing like what we had in the first wave or even the Christmas wave. So again, evidence that the vaccine is working incredibly well. If you go down to the second graph, the darker lines are COVID deaths, the red lines, the greys are all deaths. So again, at the beginning, there's a little something in here where the very first lockdown started and we had a lot of red deaths. We also had the dotted line seasonal average. We also had some deaths in there which weren't attributed to COVID, which probably were COVID. So we've possibly underestimated some COVID deaths in the first wave a little bit. You've then got all the deaths coming through over time, and to the right-hand end, and again, really since, frankly, probably March this year, we've bumped along for a long time below seasonal average deaths, a little bit above. But if you were to average out the whole year, even from January this year, you'll find that this year, so far, for our region, there'll be a relatively small number of excess deaths. Last year, there'll be a big number. This year, I expect it to be a lot smaller. And finally, just to show you the latest estimates we have on mortality rates, and again why the age has such an impact. The median overall ages is 0.18% mortality rate. So 0.18% of infections lead to death. Now, this, first of all, these are all overestimates because we never count all infections. You can never quite count all the infections that are there. You can only count the ones you test. So there's already going to be an overestimate of all of these figures anyway. But if you look at the 75 pluses, currently it's about 2.6%. It's about 1 in 40 of people over 75 who catch COVID are dying of COVID. You can see the numbers in the lower age groups are absolutely tiny numbers. 1 in 100,000 type numbers in the lower age groups. So it matters enormously. Age still remains the biggest risk factor. People I worry about the most are unvaccinated people, full stop. But unvaccinated older people are the biggest risk. And there's data which I can't really share in slide form, but what I can do in terms of just wrapping up and finishing, it can describe to you, is that when you look again at the vaccination programme, and we've looked at data on the deaths through the entire calendar year of 2021. If you look at deaths under 40, there's nobody who's died of COVID under 40 who's been double vaccinated. 0 deaths in the double vaccinated under 40. And I don't think we'll make enough of that type of, I mean, thank goodness there's been relatively few deaths under 40, but all those sadly who have died under 40 are people who haven't had the chance to be vaccinated early in the year or haven't been able to be vaccinated later in the year. And still, the bulk of the hospital pressures now, the people dying are now on people who are not vaccinated, as opposed to those who are vaccinated. So I'll stop there. I only have about 5. I am doing a major call at 11 o'clock with counties across the country, so I don't have a lot of time for questions, but I'm very happy to take any brief questions or remarks if anybody's got any for about 5 minutes. Over to you. I'll try and have a quick look in the message bar while I'm looking.
Can you hear me?
Yes, I can. Yes.
Brilliant. So I'm in the big room again. We had to move halfway through because they kicked us out of a lecture theatre.
All right. Oh dear.
Just ask, any students, if you want, has anybody got any questions that you want to ask Peter? Or are you happy? Yes. We have one question from the room, if that's okay.
Yeah, of course. Yes.
Do you want to come to the front?
Hello, Peter. It's Mithila. Good morning again.
Hi, Nicola. Good morning.
Okay. Actually, what measures or what are the policies should we take in case of vaccination quality program control check index? Vaccination program quality check index.
Yeah. Okay. So the vaccination program, I think it goes back to some of the recommendations we made last year about being paid far more attention to being culturally sensitive about not just vaccination programs, about how we approach all services for different groups of people. I think we haven't paid enough attention to that for a long time. I think the pandemic has demonstrated that. So when we have something like the vaccine, which sadly some people have hijacked for their own purposes, some anti-vaxxers have put out an immense amount of false messaging. We've been on the back foot, and we haven't worked enough with communities to help communities understand the benefits of the vaccine, why it's safe, and how it saves the lives of people. One of the things I've been tackled on about the vaccine on the media, and one of the questions I've been asked is, have I been vaccinated, my children been vaccinated, and stuff like that. And the answer is always yes. And I do feel like asking people sometimes, and people like me are trying our very best to save lives, which is what we're actually doing here, to help people get vaccinated. Do people who are portraying some of the message about the negative message about the vaccine really think someone like me is trying to do ill? trying to do harm, is a bad person. You know, it does actually puzzle me. So I think we need to do all we can to help people understand the benefits of the vaccine, to explain why the myths are myths, and to show the data. The data is just so staggering that the vaccine is successful. We haven't had the scary side effects anybody's talking about, and it's a huge success story.
Okay, I have another question. Actually, another 2 questions. I'm so sorry.
It's okay, but I have 3 minutes, so be quick.
Okay, so we all do a lot of research about the health inequalities or inequities. So as a public health expertise, do you think that health inequality is not noticeable among vaccination program regarding Pfizer program, Moderna program, Moderna vaccination and AstraZeneca vaccination?
Okay, so I think we need to do more work on inequalities in all vaccine programs, not just the COVID vaccine program, because there's also inequalities in other vaccines. There's also inequalities in screening uptake. So if you look at bowel screening, breast screening, cervical screening, there's inequalities in ethnic minorities as well for accessing those programs as well. So there's a fundamental issue. I think somebody's made a comment in the chat about, is there a mismatch between, or lack of trust, if you like, between health authorities and people who plan these services and the recipients of the service in different cultural groups? And I think the answer is maybe not mistrust, but misunderstanding of each other's approaches. And I think we have to do a lot more to understand cultural sensitivities across all of these programs, so not just the vaccine program. When it comes in particular program around you mentioned the Pfizer, AstraZeneca, Moderna, etc. You know, those vaccines have been now tested in trials at different parts of the world, and better than the trials, we now have hundreds of millions of real life data. We have 90 million vaccines being administered in this country, so we have real life data as well as the trial data. And I think we have to look at the real life data as much as the trial and the study data. And I think maybe at the beginning you can argue maybe how we explain some of these things to different communities could be improved. I absolutely would go along with that. I would love to be there in the room with you all today rather than doing this remotely and talk. I could talk about this literally all day with you all today, and I'd love that chance at some point. It's such a fascinating, such an important subject. After one more brief comment, I'm afraid I do have to. I'm actually presenting at another call at 11 o'clock, so I do have to be quite sharp for it.
Thank you, Peter.
Anyone who wants the last word?
There's nobody else in the room.
Nope.
We don't really have time, do we? Oh, one really quick one.
Really
Make
quick.
it the quickest question of your life.
Hello, Peter. It's Shafkat once again.
Hi.
Just a short question. We talked about inequalities and everything. We know the vaccine program has taken different parts of the world, but still in the developing worlds, we are still having shortage of vaccination. So,
Yep.
as we are living in an era of one world, one health program.
Yep.
So, what are the strategies you want to take for the developing countries to develop and to spread these vaccination programs and to
Right.
combat the myths?
Great question. I mean, I'm very clear on this. I've said this in multiple places. It should be our priority, along with the rich nations of the world, to vaccinate the entire world as fast as possible. For me, there's a moral responsibility. I also think it's a public health responsibility and the responsibility of the rich to help the poor. So I would like to see, for example, if you want to ask for a strategy, I would like to see our government partner with a poor country and vaccinate the entire country. And then when they've done that one, partner with another poor country and vaccinate the entire country. And I think all the rich countries, every rich European country should do that. America should do that. China should do that. Russia should do that. And that way, we get the whole world vaccinated a lot quicker. Because none of us are out of this till we're all out of this. So we need to get the whole world vaccinated as fast as possible. My straightforward answer. Governments need to do more.
Thank you so much, Peter. I'm well aware that it's 10:59 and you have about 60 seconds to get off.
Yeah.
So thank you so much for your talk today. It's been really interesting, and thank you from both the students and from the public health team for coming in, taking time out of your day to come in and chat to us. That's been absolutely amazing.
It's an absolute pleasure, and I'd love to do it more often. As I say, I'd love to be in the room today. Maybe circumstances don't allow it just yet, but I'd love to be in the room today with the students and maybe get that chance soon.
Absolutely brilliant. Thank you so
Thank you,
much.
everybody. Thank you. Bye-bye.
Thank you.
Bye.
Bye.